And I want to preface my talk by saying just a couple of things. I don't have the comedic timing of Dr. Electiar, first of all. And secondarily, if you felt that the treatment of the adjuvant therapy of endometrial cancer was confusing, then my talk is going to, I think, thoroughly confound you. And that's really where we are at this point, unfortunately. So I have no disclosures for this talk. And just by way of background, we do know that endometrial cancer is the most common gynecologic malignancy in the United States. There are approximately 55,000 new cases of endometrial cancer in the United States yearly, and it accounts for approximately 11,000 deaths per year. The median age at diagnosis is 61. Risk factors that are associated with this specific malignancy are obesity, early menarche, late menopause, nulliparity, certain genetic syndromes such as HNPCC, Lynch syndrome, that are acquired genetic mutations due to abnormalities in the mismatch repair genes that are of high penetrance and are associated with early onset endometrial cancer, along with other malignancies such as colon cancer, hepatobiliary cancers, GI cancers, brain tumors, et cetera. Additionally, mutations in BRCA genes as well as PTEN gene leading to Cowden syndrome are also associated with a small proportion of endometrial cancer. Other risk factors that are implicated include diabetes mellitus, complex atypical hyperplasia, which is considered a precursor lesion, and the use of tamoxifen. So endometrial cancer is comprised of numerous histologic subtypes, and these subtypes are broadly classified into what we call low-grade tumors and high-grade tumors. Low-grade endometrial cancers are mainly comprised of what we call FIGO grade 1 and 2 endometrioid tumors, and high-grade endometrial cancers are comprised of the others, which include grade 3 endometrioid cancers, serous cancers, undifferentiated or dedifferentiated subtypes, mixed cell types, clear cell cancers, and the other rare forms such as carcinosarcomas, mucinous and squamous cell histologies. And I think it is still useful to use this sort of way of looking at endometrial cancer. We also classically have thought of endometrial cancer as two specific subtypes, what we call type 1 and type 2 cancers, and this is based on distinct sort of clinical pathologic as well as molecular characteristics that these various subtypes have. So type 1 cancers, again, are considered the grade 1 or grade 2 endometrioid adenocarcinomas. They are associated with a more favorable prognosis, and these are more common types of endometrial cancers. It's felt that these are more dependent on estrogen and typically more responsive to hormonal blockade. Type 2 cancers have classically been felt to be the more aggressive subtypes of uterine cancer. These are the higher grade, more rare forms of uterine cancer and have been associated with more distal metastases and essentially lack of response to hormonal blockade. These account for approximately 10% of the primary endometrial cancers that we see at initial diagnosis, but do account for approximately 40% of recurrent disease cases. Now, with the advent of the TCGA project and other studies that have characterized the molecular landscape of endometrial cancer, we know that the PI3 kinase mTOR pathway is a very important signaling pathway in that it drives many hallmarks of cancers in multiple malignancies. We know that constitutive activation of this pathway is common in endometrial cancer, and that this pathway is associated with aggressive disease and poor prognosis in this disease. Alteration in this pathway has been described in 92% and 60% of type 1 and type 2 endometrial cancers, respectively. And this pathway has more alterations in it than any other cancer subtype that has been studied in the TCGA thus far. So this is just a slide that basically very briefly looks at the molecular characterization of endometrioid versus non-endometrioid uterine cancers. And you can see that the endometrioid subtype tend to have a higher prevalence of the PI3-AKT pathway alterations. Additionally, there is a fair percentage of alteration and mutation of beta-catenin, as well as microsatellite instability. And when you look at the non-endometrioids, these cancers tend to have a very high prevalence of P53 mutation, as we have learned throughout the day, but also have overexpression of HER2. And have a lower prevalence of abnormality in the PI3-AKT signaling pathway, though still present. The Cancer Genome Atlas Project was an integrated genomic, transcriptomic, and proteomic characterization of over 350, it was actually 373 cases of uterine cancer, and these were primary surgical samples. And as a consequence of that endeavor, we realized that endometrial cancer, as Dr. Electiar pointed out, is actually a disease that has 4 molecular phenotypes. So there's the POL-E ultramutated group, where there's a mutation in the POL-E catalytic subunit of the polymerase epsilon, there's a MSI hypermutated group, there's a copy number low endometrioid-like group, and there's a copy number high serous-like group. Interestingly, these various molecular phenotypes were associated with differences in progression-free survival. So the POL-E ultramutated group tended to have the best progression-free survival, whereas the copy number higher serous-like group really did the worst. We also were enlightened by other molecular findings as a consequence of this study, and we realized that endometrial cancers actually have properties that they share in common with colorectal cancers. For example, high frequency of MSI, as well as POL-E mutations, and these lead to ultra-high mutation rates. Additionally, like colon cancer, there are mutations in activation of the Wnt and beta-catenin signaling pathway, but unlike colon cancers, there is exclusivity of KRAS and beta-catenin mutations in these cancers. As far as the serous cancers are concerned, we saw that this particular subtype has much overlap with the basal-like breast cancers and high-grade serous cancers of the ovary, including mainly non-silent p53 mutations and extensive somatic copy number alterations. But unlike those malignancies, these serous-like cancers also had a high frequency of PIK3CA ARID1 mutations, which were unique and different from the other subtypes. So with all of this data and the fact that this is the most common gynecologic malignancy, what is the current status of affairs? And as I mentioned, despite all of this wealth of data, there are treatment limitations. And this stems from the fact that there is still limited efficacy of current treatments for advanced endometrial cancer. That stems largely from the fact that this is a very molecularly heterogeneous group of diseases. Molecular profiling is not routinely performed across the board for these cancers. There are no approved molecular targeted agents for the treatment of advanced endometrial cancer, with the exception of Megace, which was approved in the 1970s, and that too for the palliative treatment of endometrial cancer. Currently, there are no validated predictive biomarkers, though many groups are working on this ardently. Additionally, there's limited histopathological and molecular selection of patients for particular studies, and even routine treatment, which we know is problematic and that it is important to do so, given the different prognoses of the different molecular phenotypes of this disease. So what are the options? The options for advanced disease at the current time include combination chemotherapy, single-agent chemotherapy, endocrine therapy, and targeted therapies. And there are a number of agents that have been evaluated, as I will quickly try to go through. And these have channeled and targeted the angiogenic pathway, the PI3 kinase mTOR pathway, and a myriad of other pathways, which we'll discuss. So I want to start with chemotherapy very briefly, because this was an important trial in patients with advanced endometrial cancer who are chemotherapy naive. The study took patients that had advanced stage or recurrent disease but no prior chemotherapy and randomized them to TAP, which was a 3-drug regimen comprised of doxorubicin, cisplatin, paclitaxel versus Taxol and carboplatin. And what this revealed is that the curves were on top of one another. So the median overall survival essentially of both regimens was comparable. And therefore, this study established that Taxol and carboplatin is non-inferior to the 3-drug regimen and much better tolerated. This then became the standard approach and led to this study, GOG-86P, which was led by Dr. Agajanian. The premise for this study came from the fact that we knew that bevacizumab, which is a VEGF receptor blocker, had activity in single agent in this disease population. We also knew that mTOR inhibitor temsirolimus was active in this disease, and that exabipolilone had activity as a single agent in endometrial cancer. Hence, this trial took the same population of patients, so chemotherapy naive advanced stage patients, and randomized them to Taxol, carboplatin, bevacizumab with bevacizumab maintenance, Taxol, carboplatin, temsirolimus with temsirolimus maintenance, and exabepolilone, carboplatin, bevacizumab with bevacizumab maintenance. And essentially what this study showed is that the Taxol, carboplatin, bevacizumab arm had superior overall survival compared to the other arms, and also compared to historical controls. At the current time, there's integration of translational science and other clinical endpoints that is ongoing. Dr. Agajanian is also spearheading another trial in this exact same patient population, where we're looking at carboplatin paclitaxel plus metformin with metformin maintenance versus carboplatin paclitaxel placebo with placebo maintenance. And the rationale for that trial is that metformin is a drug that has anti-cancer properties. This agent has both direct and indirect effects in management of hyperglycemia. It lowers insulin and glucose levels in the bloodstream. It has direct on-target effects by activating AMP kinase, thereby inhibiting the mTOR pathway. And so it's very logical that this combination is being tested in this chemotherapy-naive, mostly obese patient population. So what about single agents? Not everyone in our patient population that we're talking about is fit. So we have many patients that have poor KPS, performance status, or have other comorbidities that do not allow them to go on to doublet-based chemotherapy. So what do we do with those patients? Well, there are a myriad of trials that have looked at single-agent chemotherapy agents, and there are good responses. So drugs that are active include doxorubicin, the platinum drugs, Taxol, ifosfamide, topotecan, and response rates have varied from 20 to 37% in this population. So these are, again, single-agent chemotherapy trials in patients that have had no prior treatment. What about in the second line? Well, as you can see from this slide, response rates to second-line chemotherapy in this disease are dismal, and they vary from 4 to 13.5%. In GOG 129C, which is that top portion that looked at paclitaxel in the second-line setting, the response rate is 27.3%. However, basically no one on that trial had a prior taxane. The remaining studies, though, do show you that in the second-line setting, response rates are very poor and very short-lived. I'm going to skip this slide due to time. So let's talk a little bit about targeted therapies and sort of where we are at this point in the landscape of treatment of advanced endometrial cancer. So a myriad of agents, including the progestins such as Megase and metoxyprogesterone acetate, selective estrogen receptor modulators such as tamoxifen, the aromatase inhibitors such as anastrozole and letrozole, and pure estrogen antagonists such as fulvestrant have been evaluated in a number of gynecologic oncology trials. Essentially what you can see from this slide here is that response rates range from 9 to 33%. The highest response rate was seen in a trial that combined tamoxifen alternating with metoxyprogesterone acetate. And progression-free survival ranges from 1 to 10 months. The best results in most of these studies were seen in patients that had low-grade endometrioid tumors. And again, as I mentioned, at the current time, Megase is the only approved FDA-approved treatment for the treatment of advanced endometrial cancer. In terms of the angiogenic or anti-angiogenic experience, we've looked at a number of drugs that target this pathway. We know that VEGF expression is increased in endometrial cancer, that it is associated with higher histologic grade, and is associated with myometrial invasion and poor outcomes. So this journey began with thalidomide in 2007, and a myriad of other drugs have been investigated, including sorafenib, bevacizumab, aflibercept, lenvatinib, bevacizumab in combination with temsirolimus, sunitinib, cediranib, and others. Of these many, many agents, really the drugs that have shown activity include single-agent bevacizumab. That trial was led by Dr. Agajanian in 2011. Aflibercept, which was resulted in 2012, the combination of bevacizumab, temsirolimus, and lenvatinib. So the trial that was led by Dr. Agajanian in 2011 was with single-agent bevacizumab. Patients had 1 to 2 prior regimens. And this study was associated with a response rate of 13.5%, a median progression-free survival of 4.2 months, and a median overall survival of 10.6 months. However, 40% of patients were progression-free at 6 months. And what was really great to see is that the drug was very well tolerated. So there were no fistulae reported, no perforations, and there were only 3, I think, grade 4 events on that trial. The aflibercept was also investigated, targets VEGF just like bevacizumab, and had a progression-free survival at 6 months that was comparable to bevacizumab, but much, much more toxic. 32% of patients came off that trial due to toxicity. The bevacizumab temsirolimus arm also has shown activity. Progression-free survival at 6 months for that combination was approximately 47%, but again, nearly 40% of patients came off study due to toxicity. So of that group, bevacizumab has shown efficacy and was the best tolerated, and has received an NCCN Compendium 2A listing, so that now we're able to use this agent for the treatment of advanced endometrial cancer. Lenvatinib is a multi-tyrosine kinase inhibitor that has shown activity with a response rate of 14.3%, and this drug is now being combined with other agents in ongoing clinical trials. So what about single-agent mTOR inhibitors? So based on our rationale to target the PI3 kinase AKT-mTOR pathway, a number of phase 2 studies have investigated mTOR inhibitors in the single-line setting for advanced endometrial cancer patients. And these include temsirolimus, everolimus, ridoferolimus in both IV and PO formulation. What you can see from this figure here is that these agents have modest responses, and that these responses occur across histologic subtypes. Predominantly, these agents result in stable disease that ranges from 18 to 53%, and response rates range from 0 to 14%, with best responses seen in patients who are chemotherapy naive. mTOR inhibitors have also been evaluated in combinations with other agents, including hormonal therapy and with chemotherapy and chemotherapy plus bevacizumab. I'm going to just briefly talk about the first two studies. So first reported was a phase 2 trial with temsirolimus alone or in combination with Megase alternating with tamoxifen. The combination arm showed an objective response rate of 14%, and 52% of patients had stable disease. However, due to a number of thrombotic events, that arm was closed, but responses were equivalent in patients who had chemotherapy or who were chemotherapy naive. Mutation analysis was done on this clinical trial. And essentially what it showed is that increased PFS and response rate were noted for patients with AKT1 mutation. There was also an increase in PFS but not response rate for patients that had CTNN1B mutations, and that the two patients with TSC mutations did have objective response. No other statistically relevant mutations were seen that would correlate with response. And then the combination of everolimus and letrozole was reported recently, and this was a phase 2 trial that looked at the combination in patients that had had 0 to 2 priors. Objective response rates were high at 32%. The combination was well tolerated and resulted in stable disease in 8% of patients. So given the modest activity of the single-agent mTOR inhibitors as well as the combination with other agents, we've evaluated a number of molecules that target other components along this pathway. And the first was a drug called MK2206. This was a phase 2 trial with patients who'd had 1 to 2 prior lines of therapy. Patients were stratified by PIK3CA mutation status. This drug was administered once weekly, but unfortunately did not meet the pre-specified goal of 4 or greater responses. Only 1 patient had a response, and sequencing times 2 was unrevealing in this case. The next study was BKM120. This is a PI3 kinase inhibitor. This is a very busy slide, but the bottom line is that this drug was very, very toxic. Despite being tested at 2 dose levels, over 87% of patients experienced grade 3, grade 4 toxicity, and this drug was also associated with 0 objective responses. Hence, it was closed early, and it was felt that this had an unfavorable safety profile and minimal activity in endometrial cancer. This leads us to piloralsib. So it was a phase 2 study of this agent that is also a PIK3 kinase inhibitor. Similar patient population, recurrent disease, 1 to 2 priors. 2 formulations of the drug were tested, and it was associated with an objective response rate of 6%. On sequencing analysis, there was no association between molecular alterations and clinical activity, and this drug, while having a favorable tolerance, had minimal anti-tumor activity in advanced endometrial cancer. That leads us to epidemiology. So this is a phase 2 trial of this agent, which is a dual pan-class 1 PI3 kinase mTOR inhibitor. Again, same population of patients that had 1 to 2 priors. We administered this drug on a daily schedule. They received it for 28-day cycles. And patients with type 2 diabetes who were only on oral hyperglycemic agents were allowed as long as they had a fasting blood sugar of less than 160 and hemoglobin A1C of less than 8.5. The progression-free survival at 6 months was 20%. The median progression-free survival was 3.5%, and the overall survival was 17%. Sadly, the objective response rate was 6%, and evaluation of anti-tumor activity was very limited, unfortunately, in this study due to tolerability, especially in the diabetic patients. Most patients on this study, unfortunately, came off prior to their first tumor assessment. So that was very unfortunate. We did do a comprehensive biomarker analysis of tumor samples using MMP-seq. P10-IHC analysis was also performed, and copy number alterations for ERBB2, IGF-1R, MET, MYC, CCNE1 were assessed by real-time quantitative PCR. And essentially what we showed was that 67% of our patients had an alteration at some point in the PI3 kinase pathway. Endometrioid patients had higher Frequency of alterations compared to serous patients, as you can see from this figure, it was 76 versus 67%. And copy number gains, again, as you can see at the bottom of this figure, were almost exclusively seen in serous, clear cell, and mixed histologies. Overall, we also found a lower prevalence of PI3 kinase pathway mutations, which we felt was probably secondary to the fact that we captured the more serous-like endometrioid patients, as shown by the TCGA data. Up to 1/4 of the grade 3 endometrioid patients behave more like serous-like tumors. So what other targets have we looked at? Well, we've looked at the EGFR pathway. This pathway is overexpressed in both type 1 and type 2 endometrial cancers and does mediate growth and metastases. But despite the success of these agents in other malignancies, we have not seen similar responses in endometrial cancer. So both gefitinib and lapatinib were evaluated. Gefitinib is a pure EGFR receptor blocker. Lapatinib blocks EGFR and HER2, and the objective response rate was 0 to 3.8%. Brivinib is an FGFR2 and VEGF blocker. In a phase 2 trial of this agent, we did see an objective response rate of 10.6%, stable disease in 27.9%. So there are plans to evaluate this agent further in endometrial cancer. The MEK inhibitor pathway and MEK inhibitors in combination with AKT inhibitors have all been suspended early due to great toxicity and lack of efficacy. So where are we at this point? Essentially, the management of endometrial cancer is straddled across two arenas. One here are the cytotoxic. So there we have the platinum drugs, the taxanes, predominantly paclitaxel, the anthracyclines, both doxorubicin, liposomal doxorubicin, and topotecan, and all have modest activity in the frontline setting, and again, in second-line response rates are really quite poor. As far as targeted therapies are concerned, we do commonly use progesterone agents, tamoxifen, aromatase inhibitors, migestrol alternating with tamoxifen, mainly for the lower grade endometrioid tumors. Thanks to a study by Dr. Agajanian, we now have the use of bevacizumab for patients with advanced endometrial cancer, and also thanks to the initial studies evaluating temsirolimus, we now have temsirolimus that we also use for the treatment of advanced endometrial cancers, again, patients that are relatively chemotherapy naive. So what should we consider for future endometrial cancer studies, and what have we learned? Well, I think that contemporary biopsies are very important. We know that there's tremendous heterogeneity that occurs between primary tumor and recurrent disease. In fact, it's up to approximately 40%. So biopsies at time of diagnosis, at time of recurrence, and post-treatment biopsies are very, very important to identify mechanisms of resistance. We also need to integrate molecular data prospectively to match proper patient to proper trial. We need to consider and refine targeted therapy combinations. We have to set a high bar for selecting new therapies, and we need stricter patient selection criteria based on known toxicity profile of agents that we've used. At the current time, there are a number of wonderful phase 1, phase 2 trials that are ongoing that are evaluating really, again, a number of pathways in these cancers based on the data that we've learned so far in terms of what pathways are abnormally expressed. There are good drugs looking at the mTOR pathway, PI3 kinase inhibitors, TDM1 in patients with HER2 amplification, neratinib in patients with HER2 mutation, and a number of other agents that are currently under development and are ongoing. I also want to mention this briefly. I know others will be talking about this, but I think immunotherapy in the management of advanced endometrial cancer is also relevant. We know that POL ultra-mutated and MSI hypermutated endometrial cancers are associated with increased neoantigen load, increased numbers of tumor-infiltrating lymphocytes, and higher expression of PD-1 and PD-L1 in immune cells. These findings clearly, therefore, support trials of immune checkpoint inhibitors in endometrial cancer, and particularly in hypermutated endometrial carcinomas. And with that, I end, and I'd like to thank the entire DMT and Carol and Marty and Paul and Dr. Spriggs, and thank you very much.